Good morning, ladies and gentlemen. Thank you for being here on a Saturday morning. We have 3 distinguished speakers for the next 90 minutes, so let's start now. We in Singapore are really lucky to have Prof. Leong's guidance on starting up our selective T-depleted haplotransplant program, which is the topic of our next speaker. So since the 2 talks are quite closely related, we shall combine the Q&A after the second talk. So next, it's my pleasure to introduce Prof. Koh Leong Piew, Senior Consultant, National University Hospital. Prof. Koh's research interest is in alternative donor transplant. In particular, he has been most involved in pioneering this haploidentical transplant with selective T-cell depletion in the past few years. So let's hear his presentation on the experience of haplotransplant using selective ex vivo alpha-beta T-cell depleting and memory T-cell at back. Prof. Koh.
Thank you very much, Ye Cheng, for the kind introduction, and I'd like to thank the committee for inviting me to speak at this very wonderful meeting on a Saturday morning. So after hearing what Prof. Leong has mentioned about all the T-cell depletion technology in pediatric settings, I actually get very nervous because he has set the bar too high for me to. Anyway. Where's the forward button? This one, okay. Okay, so my talk is purely on T-cell depleted haploidentical transplant in the setting of adult, but I just like to give some background for those patients, those of you who are not familiar with this work. As you all know, this is a very standard slide that we show to all the transplant trainees. The transplantation for patients requires a full match transplant, and this is what we have been relying on conventionally for the last few decades. So we know that about 1/3 of patients are able to find a matched sibling donor from the family, leaving the rest having to explore the alternative options either from the matched unrelated donor, unbiological cord blood, or haploidentical transplant donors. So this is the classical hierarchy of the donor choice or donor selection they have been relying on for the last few decades. Most of us prefer to use a matched sibling donor, and having shown what the previous slides, about 70% of patients may not be able to find a donor, and therefore we have to look for alternative sources, including unrelated donor as a first choice, the next choice of option, and the rest we have to rely on either cord or haploidentical donor. Haploidentical donor, as you know, offers all the advantages as an alternate donor options. As you can see from this chart here, it is always almost immediately available. The donors are highly motivated. We are able to harvest large numbers of cells, and we have the additional advantage of harvesting extra cells for future use or in case the patient has relapse or infections, either for DRI or for memory T-cell infusion like what Prof. Leong has mentioned. And also, more recently, we are increasing data showing that it has the advantage of increased, more potent graft versus leukemia effect, as what Prof. Leong has mentioned in this slide. But haploidentical donor, as you all know, everybody knows that it has some of the major disadvantages from all the historical data with higher risk of graft rejection, more severe GVHD, longer time for immune reconstitution because of the T-cell depletion, and of course, predisposing these patients to increased risk of infection. So recently, with all the advantages of haploidentical donors as the alternative donors, including more rapid availabilities of donor, shorter time interval to transplant, there's significant increased use of haplo donor as a donor choice, as you can see from these 2 sets of data from CIBMTR and APBMT. And in fact, you can see clearly from here, the number of transplant using haploidentical donors has exceeded that of matched sibling donor recently over the last few years. So in Singapore and in our hospital, we also see the same trend. The number of transplant using haploidentical donor has increased significantly. In fact, last year you can see that we have done more haplo donor than that of matched sibling donor and matched unrelated donors. This slide shows the timeline of advances in HSCT over the last 60 years, as you can see, the development of haplo-donor transplant, starting from what Prof. Long had mentioned with the CD34 enriched peripheral blood stem cell transplant, pioneered by the Perugian group in Italy, and then followed by the development of PTCY by the Johns Hopkins group, and then more recently, the more refined selective T-cell depletion, the use of selective T-cell depletion for haploidentical transplant, more recently in our hospital and in some other centers in Europe and US. The increase in numbers of haplotransplant has also been partly fueled by the usage of these two important T-cell depletion protocol, the platform, sorry. As you can see on the left, you can either do an in vivo T-cell depletion using drugs like alemtuzumab, like Campath, antibodies like thymoglobulin, and more recently, the use of PTCY or post-transplant cyclophosphamide. This is what you're more familiar with, the use of PTCY, giving high-dose cyclophosphamide on day 3 and 4 with the hope to deplete all the proliferative alloreactive T cells pioneered by the Johns Hopkins group. The one that we're more interested and we are much more involved recently is the use of ex vivo T-cell depletion. It has been that of CD34 selected enriched peripheral blood stem cell, but more recently, we are moving towards the use of negative depleted, alpha beta depleted haploidentical stem cells. So over the last few decades, as Prof. Leong has mentioned, we have witnessed some important landmark evolutions of graft engineering with a shift from CD34 enrichment to pan-CD3 depletion, and more recently, the alpha-beta T-cell depletion. So an improvement in the improved understanding of the immunobiology of the graft versus host disease, coupled with the evolution of this graft engineering, has allowed us to refine the techniques of T-cell depletion in our patients undergoing haplotransplant, as you can see from here. And this is what Prof. Long has just mentioned, showed. We are now able to infuse graft not only containing graft CD34 cells, but also important immune effector cells such as NK cells, gamma delta T cells, dendritic cells, memory T cells, Treg, and also B cells. So this partial T cell depletion platform selectively removes T cell subsets responsible for GvHD, while preserving all these important immune cells, including alpha beta T cells, NK cells, and other important accessory cells, not only to facilitate engraftment, but also to provide immune reconstitution and graft versus tumor effect. Also, in addition to that, some murine studies performed in the 2020 years ago by Nelson Charles in Duke University and also Warren Stromczyk in University of Pittsburgh have shown that naive T cells of CD45RA cells causes more severe GvHD, whereas the memory T cell, which is a CD45RO positive cells, preserve some important graft T cell functions like GVT without causing GvHD. So I'd like to show you some important publications over the last 10 years. 2 studies are from pediatrics and 1 from adults. So the first one is from the Italy group, pioneered by Franco Locatelli, and the data was just updated by his colleague, Dr. Murley, in the Blood Journal this year, looking at 213 children with high-risk leukemias, were all given haploidentical transplant using alpha-beta depleted and B-cell depleted stem cells. They were all given fully myeloablative PrEP regimen, TBI-based mainly. Also, some of them are given chemo-based regimen. These patients were all given the ATLG, which is the grafenolone, given on day -5 to -3, which is very important, has an important implication because that affects some of the outcomes that we see. These patients were not given any GvHD prophylaxis. As you can see here, not unexpectedly, GvHD is severe. A severe GvHD is low. There's no graft versus host disease grade 4 seen in this cohort of patients. GvHD grade 2 to 3 is only seen in 14.7%, and a low chronic incidence of chronic GVHD was only seen in 8% of patients. Relapse rate is not that low, it's about 22%. Remember, these are all high-risk patients. TRM, as expected in children, is below 5%. They have a very impressive 10-year overall survival of 75%, disease-free survival of 71%, GVHD relapse-free survival of 65%. In that study, they did not show any impact from the cure mismatched donors. I think this is likely because of the use of the ATG that's given close to the infusion day. And this is a study that was presented by Prof. Leong. I think we can see that. Essentially, what I want to show you is that the use of haploidentical donor using the cure favorable donor allows the cure of patients with children with high-risk leukemia. And you can see from here that the use of parental donor, which is all haploidentical donors, confers the best outcome as compared to that seen in sibling and even cord blood and other well-matched donors. And the relapse rate is the lowest among these cohort patients. GVHD, chronic GVHDs are also lowest among this cohort patients. I'd like to show you another study that was published by the German group, the German multi-center studies with 30 adults and 30 children. The transplant protocol is what Prof. Leong has mentioned, consisting of fludarabine, tautilpa, and melphalan, with and without the use of total lymphoid irradiation in some patients and ATG in other cohort patients. Note that this ATG was not given near to the infusion day, but rather it was given -12 to -9. And as expected, the engraftment is robust and rapid. Only a few patients has lost a graft or did not get engrafted at all. GVHD in this patient is about 10.1%, grade 2 to 4. GVHD is 3 to 0 was 0. No GVHDs of grade 3 to 4 was seen. However, the chronic GVHD is actually not low. The TRM was about 70%, and this is encouraging, taking into consideration these are all adults and children. Relapse rate was dependent on the disease status at the transplant. Overall survival is in about 60%, with the GVHD relapse-free survival of about 39%. I would like to actually show you what we have done over the last 7 years using a similarly designed protocol using alpha-beta depleted plus memory T cells at back for our patients with heme malignancy. So the first study analysis was performed about 2 to 3 years ago, looking at about 100 adult patients and about 7 children with heme malignancy, giving this alpha-beta depleted transplant protocol. We call it Haplo 2017 because it was first done in 2017, January 24 in Singapore. So essentially it consists of, fludarabine, tautilpa, and melphalan with the use of total nodal irradiation initially, but we subsequently modified the protocol to that of total body irradiation because of some logistic challenges that we faced. These patients were all given alpha-beta depleted stem cells. In addition to that, we also infused 45RA depleted memory T cells. So there are some modifications that we've done over the last few years. Number one, we have moved from total nodal irradiations to TBI because of some logistic challenges that we face in some centers. We have added, in addition, a short course of immunosuppressive therapy. We have kept the cell dose at about 10 million and also kept the memory T cells below 2 million cells, 2 million per kg. So this paper was presented at ASH 2 years ago, and we have shown overall survival of 70% at 2 years, EVM-free survival of 59%, and GRFS of 57%. As you can see from here, if you compare this data against that of BMT-CTN that randomized adult patients with heme malignancies to receive either a double cord or haploidentical transplant using the PTCY, our results are quite promising and encouraging. So I'd like to show you what we are the latest update of 145 patients over the last 7 years, between 2017 to July 2023. So the total of 145 patients, adult patients, were transplanted using this protocol. Median age is about 54 years. The diagnosis is predominantly AML, ALL, and MDS. Most of the patients were in some remission. A couple of patients had a high-risk transplant risk factors with the high-risk HCT-CI. Half of the patients received donor from their sibling or second-degree relative, the other half either from parents or children. Most of these patients were given the fludarabine tiotepa MEL-based protocol with or without TNI. Those patients without TNI, we substituted with TBI. And you can see that the T-cell depletion is quite effective. The median CD45RA depletion was in the median log was 5.0, and that of alpha-beta depletion was 5.02. So this is graph composition. The cell dose was about 6 million. Almost no alpha-beta T cells was detected in the graph, and there's no naive T cells detected in the graph. The engraftment time is quite rapid. Median time for neutrophil engraftment, it was 12 days. Platelet was 11 days. 2 patients lost their graft or did not engraft, and one patient did not engraft. The other 2 patients lost the graft subsequently, and the other 2 patients had a poor graft function that requires some salvage. And we also interestingly included 10 patients with donor-specific antibodies that predisposed them to high risk of graft rejection. And we incorporated a desensitization protocol consisting of total plasma exchange in combination with rituximab and immunoglobulin with or without Buffy-coat infusion to these patients. And we are quite pleased that all the patients engrafted with no subsequent graft failure and had quite a favorable survival after this transplant. The GVHD incidence was quite low. Chronic GVHD was only 3.7%. Acute GVHD 2 to 4 is 31%. And this is the chart showing the organs involved. Most of them had some degree or some GVHD involving the skin, plus minus the gut. Relapse rate was 22%, is quite similar to what you see in the pediatric studies. Non-relapse mortality is 17%, and this, again, must remember, these are all adult patients with many of them having multiple comorbidities. Cause of death, half of them died from relapse, the other half died from some transplant-related mortality consisting of GVHD and infection. And we did some multivariate analysis and identified some variables or factors that predict outcome. As you can see from here, what we saw is that the period of transplant, that means when the patients received transplant, did have some impact on survival, in terms of overall survival, disease-free survival, and also the NRM. DRI and HCTI has their own impact on disease-free survival, relapse, and non-relapse mortality. This is the overall survival. 67% of them were alive at 3 years follow-up. And the GVHD relapse-free survival was quite impressive at 59%. So if you stratify the patients by the year of transplant, you can see from here, patients who transplanted recently are much more likely to survive without complication. You can see the TRM is only 8.2% as compared to those patients transplanted earlier at 37%. And relapse rate was quite only affected by disease-free index. And you can see again, the overall survival and event-free survival can be separated by the time of transplant. If you are transplanted earlier, the chance of survival is much lower than that of patients who were transplanted recently. And similarly, we see the same trend for GVHD-free, relapse-free survival. And if you take out a subset of patients, those patients with very low risk disease-risk index, very low risk HCT-CI, you can see that the chance of survival is actually quite high. 77% of them are alive at 5 years to 6 years follow-up. So we try to find out why patients who are transplanted later had a better survival by comparing the baseline variables. And I think one of the things that strikes is the use of letermovir. More patients are given letermovir in the cohort as transplanted earlier because letermovir was actually approved in Singapore around 2020 or 2019. And also the other thing that we saw is that the recent patients are more likely to be given TBI rather than TNI radiation. In terms of reactivation of CMV, we can see that about 25% of patients had CMV reactivations somewhere. Just remember, these are all patients either given letermovir or no letermovir. If you can compare those patients, you can compare the studies by Francesco Marti in New England Journal of Medicine in 2017, looking at letermovir versus no letermovir in patient with transplant. The patients with no letermovir had a CMV reactivation rate of about 60 to 70% as compared to about 20 to 30% in patients with letermovir. And you can see this, we actually see a similar trend. Lowest CMV reactivation in letermovir recipient, but even in the non-letermovir patients, the CMV reactivation rate is about 37%. And the patients had a better survival if you are given letermovir, but this is only shown in univariate analysis, but unfortunately in the multivariate analysis, the impact was not as it's lost. So we ask again, what about haplotransplant again, as compared to other donor source, other transplant protocol? So this is a study that we did and presented at ASH about 2 years ago, comparing PTCY versus Haplo-17. And we did a propensity score matching to match 2 cohort patients. And these are patients who are matched for age, remission status, disease risk index, and HCT-TI. And we had 53 patients in each arms. And you can see from here that there's no difference in acute GVHD, but strikingly, the chronic GVHD incidence is very, very low, only 2% as compared to 24% in the Haplo-PTCY cohort. And there's some favorable outcome in terms of non-relapse mortality and also relapse mortality. And that translates into much more favorable overall survival, disease-free survival, and most importantly, GVHD-free, relapse-free survival. And again, using multivariate analysis, the use of Haplo or alpha-beta T-cell depletion conferred the best outcome. And this study is also compared against the benchmark using other studies that use PTCY, and we show a little bit more favorable lower incidence of GVHD and also GVHD-free, relapse-free survival. What about alpha-beta depleted stem cell versus the conventional donors? And this is a study that we submitted to ASH and has been accepted for publication in December this year. We look at a cohort of patients who were given alpha-beta depleted T cells versus match-related donor versus match-unrelated donor and some mismatch unrelated donor. And because this paper has not been officially presented, please do not disseminate. And you can see the GVHD incidence is quite similar for acute GVHD and chronic acute GVHD grade 2 to 4 and 3 to 4. But we saw a strikingly low chronic GVHD again in the alpha-beta depleted patients. And there's no difference in non-relapse mortality, but again, what we saw in pediatric patients is also shown here. We have a lowest relapse rate in the alpha-beta depleted recipient as compared to the rest. And that, again, translates into a favorable, comparable outcome with that of matched sibling donor and also unrelated donor. And the GVHD-free, relapse-free survival was the best in the alpha-beta depleted patients. And again, in multivariate analysis, alpha-beta depleted stem cell transplant recipient has the best outcome, most favorable outcome in terms of chronic GVHD and also GVHD-free, relapse-free survival. So with all this data, we start to question again, are we still going to follow this classical hierarchy of donor selection, or we should actually make some changes in our decision whether to proceed to haploidentical transplant if the patient needs a transplant and do not have a matched sibling donor. So in my last 1 slide or 2 slides, our study has shown feasibility, safety, and benefits of alpha-beta depleted stem cell and memory T-cell add-back for patients undergoing transplant for heme malignancies. It allows successful allograft in this high-risk patient with comparable or even better outcome than that of matched sibling donor and unrelated donor. Acute GVHD is quite low, and that probably leads to also a low incidence of chronic GVHD. We need to do a lot more to improve this platform by harnessing all the anti-pathogen effects, anti-malignant effects of the engineered cells. Our results provide rationales for adoption of this protocol in future. So as you can see that we are inching closer to the use of to have a perfect graft but there are still a lot of challenges to be overcome. But with a lot of grit, a lot of perseverance, I think we are quite optimistic that we are going to get there very soon. With that, I'd like to thank everybody, especially to our patients and their families, and of course, not to forget all my colleagues in SGH and Parkway, Mount In, Novena, and of course, the two gurus, Professor Wing Leong and also Dr. Ling Yecheng. And most importantly, not to forget all our BMT ward nurses, junior colleagues, stem cell lab and all the transplant coordinators. With that, I thank you for your attention.
Okay, thank you, Liang Piu, for bringing us through the whole comprehensive review of haploidentical transplant using a T-cell depleted platform. So now we can invite both first and second speakers up on the stage for Q&A session. Any questions from the floor?
Hi, very nice presentation and exciting data there. Just wanted to ask what is the ideal protocol for giving these, the memory add back? Is it a single dose which needs to be given or multiple doses? And if you're giving multiple doses in escalating doses of the memory add back, at what point do you stop giving the DLIs? Thank you.
Yicheng can actually also join. Yicheng is also an expert. Yicheng, you want to answer this question? Because you have...
We have not standardized it or refined the protocol. As of now, the standard protocol is single infusion. We decide on the day of transplant to give either 1 million or 2 million. We decided not to exceed 2 million because we are fearful of some GVHD or some cytokine release. Whether to add back like what you say, we have seen a very nice presentation by Jeffrey yesterday using prophylactic donor lymphocyte infusion using memory T cells. Very good data for prevention of relapse and also anti-infection effect. We probably need to refine the protocol further and come up with a standardized approach.
Yeah, so just to supplement a bit. So yesterday, my colleague Jeffrey Quek's presentation. So in Singapore General Hospital, we give graded increment CD45RA depleted DLI at graded increment at a median of about 3 to 4 months after transplant. That was after immunosuppression has been tapered and stopped. So for this protocol, we taper immunosuppression and stop by 2 months. And if there's no GVH, we can start at 3rd month for those patients whom we think has high risk of relapse. So we start at a very low dose of 0.1 million per kilo, and we increase by half a log, as close as every month. Sometimes together with a hypomethylating agent, and we can give many doses. We can give up to 3 to 5 million 45RA depleted DLI with very, very low incidence of GVH, and if it happens, they are all very easily controlled.
Just one final small comment is that, again, this is the fundamental difference between PTCY and this kind of precision graft engineering, is that PTCY, after you give it, you have no control. But this kind of precision graft engineering, you can decide which cells you want to give, what dose you want to give, how many doses you want to give, and at what time. So I think each of our patients are just so different. So I don't think we want to advise you on a particular regimen, but since you are the transplanter, you know the patients the best, you can utilize this kind of technology to adapt it to an individualized patient's management regimen so that you can decide dose, timing, and frequency, and so on.
I have a slightly different approach that differs from SGH. I rely on post-transplant MRD, either by flow or PCR, whatever you have. And I'm much more inclined to give them if the patient has some MRD and to prophylaxically give them, or preemptively give them before the disease had a full-blown relapse.
So there is a prophylactic versus a preemptive approach, and it remains to be seen whether which one will reduce relapse more efficiently. Yes, next speaker. Next question.
Hi, John Moore from Sydney. I'm just interested in the T regulatory cells and another immunomodulatory population of NK high. You've showed the T regs go high. Are they coming from the graft?
Yes, they're all donor-derived.
Yeah. And then secondly, NK high. Have you looked at those? NK 56 high?
Initially, they are 56 bright, but later on they become 56 dim.
Right. Have you seen correlation between those two populations and your chronic GVHD rate?
No, because the problem is that we suffer from our own success. Our chronic GVHD rate is so low.
Yeah.
So when we try to do correlative science analysis, we don't have statistical power because we only have like 2 events out of 100 patients, so it's not possible.
Thank you.
Hello, I am Dr. Muslim from Bangladesh. I'm very much glad to see my instructor, Dr. Kaliangpu, in this session. Thank you very much for your nice presentation. My question is, T-cell receptor alpha-beta depleted in haplotransplant. How T-cell receptor alpha-beta depletion can prevent graft versus host disease in haploidentical transplant setting?
So you're asking something about graft versus host disease in haplotransplant setting?
Yeah. How T-cell receptor depleted can prevent GVHD?
Sorry, how?
How prevent graft versus host disease is prevented in T-cell receptor alpha-beta depletion in haplotransplant, number one. Number two, you are using post-transplant cyclophosphamide, PTCY. How it can work in haplotransplant to prevent GVHD in vivo.
So maybe I understand the second question as how is the difference between PTCY and this ex vivo depletion?
Yes.
Yeah. Thank you.
Are you talking about the risk or the treatment or if I can understand correctly, you're saying that what is the difference in terms of the incidence of acute GVHD and chronic GVHD?
Clinical features.
No. The clinical manifestation.
Yeah.
I don't think there's any difference. Most of GVHD is what you see in your ward and the clinics, manifesting as skin rashes, diarrhea, nausea, and some liver enzyme elevation. I don't have a direct comparison, but I only have data on the incidence. That means how many % of patients develop GVHD.
How about the abortive nature?
Okay. Maybe I can elaborate on that. So in this alpha-beta depleted, we saw a significant difference in that most of these acute GVHDs are steroid responsive and they do not linger on or progress to that of chronic GVHD. And you can see from here, from the chart that I show you, the acute GVHD of grade 2 to 4 is about 30%, not different from that of PTCY, but in terms of chronic GVHD, it's very, very low. It's less than 5%. So it means that these patients' GVHDs are all steroid responsive and most of them do not progress to that of a chronic GVHD.
Thank you.
Hi, good morning. Naveen Khatri from Mumbai. So very nice talks. Both talks were excellent. The first question is, if in your protocol you did the alpha-beta depletion 90% of the graft and 10% was CD45RA. If you just reversed it, that if you did 90% of CD45RA depletion and the DLI would be the gamma delta, do you think it's possible and what could be the results of it? That's my first question.
Yeah. Please do not do that because like if you look at CD34 population, half of them are RA positive and half of them are RO positive. And if you do RA depletion, the CD34 that are left behind is RO positive. And in mice, it turns out that from Weissman study, they are the so-called long-term engrafting cells. And in human, if you just give those cells, the human cannot engraft. They will have prolonged cytopenia. So make sure that you don't use CD45RA depletion as your primary graft for the stem cell component. If you flip it, you don't have enough stem cells. But if you really want to give more gamma delta T cells or adjust the ratio of gamma delta versus NK, you can always have a so-called second collection. Sometimes we do that. And with a second collection, you have more mononuclear cells that you can play with, and you can adjust the ratio. But please ensure that there's enough 34 positive, RA positive stem cells in the graft for the first 2 months of engraftment.
My second question was for the adult patients, that's 145 patients data that you presented. So did you select the donors according to the KIR receptor ligand mismatch, or was it dependent on who was available?
For us, we don't do that, although I would like to do that for 2 reasons, because many of our patients do not have more than 1 haplodonors to choose from. We have parents, a father with only 1 child, and a patient with only 1 of the 2 parents available. So we may not have that luxury to choose. But if you have more than 1 haplodonor, many children to choose from, we probably have to rely on that.
Thank you.
Yes, Michaela.
Yes, thank you. My name is Michaela from KK. I'd like to ask if there would be any modifications in the reduced toxicity conditioning protocol for extramedullary relapses of ALL. Thank you.
Extramedullary relapse of ALL. Maybe Prof. Leong, you see more pediatric ALL. Any modification in the protocol?
No, no. In fact, nowadays with very good systemic therapy, we are seeing more and more extramedullary relapse, in particular in the head and neck area. And but we found that with our conditioning regimen, especially with the thal-tepa, and together with the potent graft versus leukemia effect, they are not only good in treating liquid tumor, but also in solid tumor. So many of these head and neck chroma that we see, or even in other organs such as kidney and so on, after the transplant, they do go away. So many of the patients I presented to you, as I mentioned, have evidence of persistent disease at the time of transplant. So we can make use of that knowledge to track the graft versus leukemia effect, and we can see that they're almost like CAR-T, they go away completely.
Maybe we take one more question. Anyone? Okay, if not, yeah, okay, time's up. Okay, so anyway, we have to move on. I'm sure both experts will be happy to answer your questions separately after this session. So the next speaker is Dr. Lawrence Ng. He is a consultant hematologist and he's my colleague in the Department of Hematology, Singapore General Hospital. His clinical and research interests includes lymphoma, cellular therapy, and geriatric hematology. His talk today is very relevant to our aging patient population, the role of geriatric assessment before transplantation and cell therapy. Dr. Ng.
Thank you, Dr. Lin, for the kind introduction. I'm sorry, I don't have a T cell or NK cell for you guys now, but I hope I can convince you that geriatric assessment is also a very important component in the transplant. I have no conflict of interest. So in this talk, I'm going to elaborate and share with you guys on the demographic and utilization of allogeneic transplant and CAR T cell in elderly, the challenges that we have currently in assessing how's the patient fitness level in a conventional way, and what are the evidence of geriatric assessment used in transplant and CAR T cell. Of course, those are the later on, we'll also talk about potentials, limitation, and the future directions. So I think this has been shared yesterday by Professor Anna Sureda and Professor Margaret on we are doing more and more older patients allogeneic transplant. So this is from CIBMTR. You can see up to about 30% of the patients transplanted in US are actually aged more than 65 years old. And this is due to all the better conditioning regime, the supportive care, all the good T cell and NK cell depletion technique, as well as improved in the induction regime. So how about CAR T? So in CAR T cell, this is from CIBMTR database, axi-cell, although known to be a bit more toxic, those patient median age was like 60 years old and 52% older than 60. Similarly, in the French registry, 900 patients, median age of 63. And lysocell, which is known to be a bit more gentle, with a median age of 70. So obviously, you can see that CAR T cell are feasible in the elderly patients. So next question is, does allogeneic transplant actually truly benefit our elderly patients? The answer is yes. So this is from a multi-center study looking at MDS patient. Of course, it's not a randomized study. They assign a category according to the donor availability. And you can see that whoever had a donor and underwent a RIC conditioning transplant did much better in OS-wise compared to a hypomethylating agent or BSC. And also at the same time, the QOL, the quality of life seems to be similar. In AML, similar study, 60 to 75 years old, and they show that the HSCT group actually did better compared to just chemo consolidation. This is, of course, most apparent at the high-risk cytogenetics on the right-hand side. And for those favorable risks, intermediate favorable risks, there wasn't too much a difference. So, but of course, we know that the older patients are usually having higher risk of cytogenetics. In a CAR T cell, Zuma-1, they actually had a sub-analysis looking at 65 years old, below 65, above 65, survival are the same. And the real-world data of axi-cell, the PFS and OS also the same. However, do note that the non-relapse mortality was slightly higher in the elderly patients more than 60 years old due to infection and secondary malignancies. However, the PFS and OS doesn't change because the younger patients seems to be a higher risk of relapse after the axi-cell. Zuma-7, shared by Dr. Ayana Sureda yesterday, equally show that in the second-line setting, axi-cell are feasible and can be done in patients more than 65 years old. In the myeloma, don't forget myeloma, they also have either cell study in the real world, looking at median age of 69 years old, and when they divide the patient into 65 or less than 65, the survival are almost the same. Alicanta and pilot study actually are looking at non-transplant eligible for patients who underwent CD19 CAR T cell, and you can see that the median age was like 70 years old, 74 years old, and they have a very good survival. So that indicates that CAR T and allogeneic transplant are feasible in the elderly patients. So what do we use to assess our patient day to day in the clinics? We use age, of course, we use Karnofsky scoring, we use HCTCI, but most important, I think a lot of us use eyeball testing. So what are the limitations of Karnofsky scoring? So this is actually started in 1940 or something, and was actually initially used to assess the patient recovery post treatment in a lung cancer patient. But of course, adapted into AML setting, transplant setting. And we know that this is very good in identifying those very poor players, less than 70. But however, when they are more than 70, it's not granular enough to show us who are the best 90, who are the not so best 90. And it's also very subjective. There are studies showing that you ask patients to assess themselves and the physician assess, there is a big discrepancy. It's also a snapshot, it's not a dynamic assessment. HCTCI was initially started by Dr. Soro and was updated in 2015. The median age was actually 59 years old, so it's not a very elderly patients. And there are also studies showing that when they are beyond 60 years old, they are actually fail to correlate to the survival outcome. So as you can see, the bottom three lines, three graphs there, when you try to separate them by HCCCI, they fail to prognosticate the survival outcome. Last, we like to use eyeball testing, and this is very subjective, clinician-based, rely on a lot of experience, and also lack of reproducibility. This picture may be a bit scary, but it's just showing that we are not subjective enough, objective enough in assessing our patient. So geriatric assessment is actually started in a solid tumor, and what is geriatric assessment? So we divided that into several categories, as you can see here, and based on two large randomized control study conducted, of course, mainly in solid tumor, a little bit of lymphoma patient, has shown that it reduced toxicity, it prevents falls, as well as reduce the discontinuations or treatment and dose reduction. At the same time, there's no difference in the survivals. So of course, because these are all in solid tumor, most of the time in solid tumor, we need some validations to be done in our population pre-transplant. I'm just showing you several retrospective studies, some of them central, some of them single center, some of them multi-center. And what you can see is the number of patients are quite robust, and they identify that deficit in instrumental ADL together with some of the physical ability does predict non-relapse mortality as well as overall survival. The two studies in the French, Italian, and the US CRBMTR actually show that it outperformed HCTCI in predicting outcome. And of course, polypharmacy is also important to predict worse overall survival as shown by the UCSF colleagues. Now look at the prospective study. So this is from Chicago, University of Chicago, and they did a single center prospective study. So after adjusted all the prognostic factors, they identified the limitation in the instrumental ADL, walk speed, slow walk speed, as well as reduced connection are associated with inferior overall survival. I like to bring your attention to the bottom. So if you can see that the hazard ratio for IADL impairment is 2.38. That actually outperformed the rest of the usual variables that we use, including the HCTCIs. So the same group, the Chicago colleagues, they actually did another analysis on after they started this transplant optimization program. And when they compared to their historical cohort in the same center, they show that when doing this optimization program, so-called intervention, they improve the outcome in both non-relapse mortality and overall survival. Of course, the caveat is you are comparing different era of the data. This is another prospective study done in UCSF, and the same thing stand out as the prognostic, highly predictive overall survival. The instrumental ADL deficit actually associated with worse outcome, and they have this physical health skill assessment predicting higher non-relapse mortality. So these two factors actually outperform the age itself. So you can see on the right, the graph C, the age doesn't differ in terms of overall survival, but the geriatric domain actually predict the outcome. So this is from Toronto. The Toronto colleague actually also did a similar thing. What they found out was actually the TUG, time up and go, which is one of the easy done tests, can be done in clinic, actually can predict both the non-relapse mortality and overall survival. So as if you can notice that the the one key factor that always stand out in predicting outcome is actually this instrumental ADL deficit. So this is actually a very easy question you can ask your patient, and it can be easily done in like 2 or 3 minutes. Similarly, another one stand out quite promising, prominently is actually the physical assessment in the form of either TUG or walk speed. I've done these two in a few patients in my clinics. It can be done, actually. Maybe my patient is not that many, but can be done. So how about multi-center prospective study with an intervention arm? So what happened was this is actually in the ASH presented last year, ASH, and 16 Spanish center with a median age of 66 years old, and the number are 900 patients. So they assess the patient frailty scale at baseline, follow on during the transplant admission, and up to 6 months. So by doing this frailty scale, they actually divided the patient into fit, pre-frail, or frail. And very encouragingly, they actually say that they can complete the assessment in 10 minutes. And this is a non-randomized way, but they do have patients enrolled into this pre-transplant rehab program. That was about 17% of the patient. And it showed that the frailty improvement from baseline to transplant admission for those patients in the program. So I'd like to bring your attention to the right side first. Clearly, you can see that fit patient always, doing better than the pre-frail patient, and the frail patients are really the poor player, with the overall survival drop from 80%, 67% drop to 20% at 1 year. So what is interestingly is, of course, this is not randomized, but those patients on the bottom here, so there are more patients improved from pre-fail after the prehabilitation to fit. So you can see the fit percentage from 20% improved to 44%. But without prehabilitation, there are more patients dropping from 29% of patients dropping from fit down to pre-frail. So that shows that you can potentially intervene and help the patient to improve their fitness so that they can end up with a better survival later on. This is presented last year, ASH. We're still waiting for publications. It's done by, led by Dr. Andrew Arts in the City of Hope. They come up with this risk model, which can predict the non-relapse mortality. It's a multi-center study, prospective study, they recruit all the patients with age more than 60 years old doing first allogeneic transplant. And the primary objective is looking at whether they can come up with a score system, a risk model system to predict 1 year non-relapse mortality. So they assess the patient at baseline, and baseline is defined as within 21 days before they're starting the conditioning regime, and these are the geriatric domains that they assess. And of course, then they follow the patient prospectively during transplant and post-transplant. It's a very large number of patients, 1,105 patients, median age of 67. And then you can see this is what usually expected in the normal population for allogeneic transplant. They have a very good uptake rate for completion of the evaluation, up to about 80% to 100%. So they demonstrated that the non-relapse mortality, even though in the median age of 67 years old, is only 14.4% at 1 year. And after they do all the analysis, they realize they actually identify 7 factors here are highly predictive of non-relapse mortality. And with that, they actually come up with a scoring system called CHARM scoring with a hazard ratio of 2.72. That actually, again, outperformed HCTCI. So so by using that CHARM scoring, they actually managed to split the patient into 3 categories with the overall survival as such. So we did a small study on our local setting, and I'd like to invite you to have a look at the poster later on. So how about CAR T cell? So CAR T cell, the data is not as robust as allogeneic transplant, but there are some studies. So retrospective study looking at a real-world DLBCL multi-center 570 patients, they identified that CIRSG, which is actually one of the assessment tool used in geriatric department, they identified a poor player with poor OS and poor PFS. And similarly, cachexia and sarcopenia are both associated with frailty, associated with poorer OS in another study. So when we look at prospective study, this is from MSKCC New York. They look at those patients undergoing CAR T cell for lymphoma, 75 patients, median 72. So again, this is not randomized, but they have a group of patients who had geriatric assessment and another group doesn't have. The result wasn't that remarkable. There wasn't any differences in the hospitalization stay, PFS, OS. But however, they identified that polypharmacy more than 5 impaired mobility can affect ICANS, and cognitions impairment actually affect both CRS and overall survival. So, and one interestingly they noticed is in the CRS and ICANS are much lower in a geriatric assessment group, indicating that those after geriatric assessment, maybe they have done something to improve whichever the geriatric domain that's having the deficit, and resulted in improvement in the CRS and ICANS risks. Another study, this is again Chicago. Chicago likes to do all this. So prospective study, single center, they actually have a median age of 73, including DLBCL and myeloma patient. So they have this recommendation after they see the patient, and then this recommendation was non-binding. That means they share this recommendation, either proceed, defer, decline to the physician, but let the physician eventually decide whether to proceed. So, of course, myeloma patient had a higher geriatric vulnerabilities index, indicating they have more prior lines of treatment. 1 year non-RAS mortality 8% and 2 years 11%. This is similar to the real-world study. And based on this study, they identified that 6 minutes walk deficit has a prediction on readmission, and instrumental ADR deficit has a higher ICANS. After adjusted on a multivariate analysis on all the LDH, CRP, which are the disease factor, they actually managed to predict overall survival by their geriatric assessment. This is very interesting findings. So what happened was there are 6 patients proceed with CAR T against their advice. So advice is actually asked them to decline, but the physician decided to proceed. And out of 6, 5 of them actually suffer from non-relapse mortality. Of course, you can arguably say that the 4 patients who did not receive CAR T after following the recommendation also die. So maybe you save 1 patient after you perform 6 against the advice. But is that worth doing that? I'll leave it to you to decide. But what we can notice this is the assessment does predict a very high-risk patient post-CAR T. So after doing all this geriatric assessment, what are we going to do? And hopefully that we can have a multidisciplinary approach trying to optimize in terms of physical, cognitions, comorbids, mental health, polypharmacy, nutrition, and social. So this is shared by the author from MSKCC saying that we are very good on the right-hand side, disease, transplant conditioning, finding the good cells and things like that. But on the left side, we also need to look into on the patient, motivation, physiological changes, as well as ecosystem supporting them. So we're still having a lot of unanswered questions. what to assess, but in my opinion, perhaps charm scoring and HAS-CT frailty score may be the one that we're going to use in the future. And when to assess? If you assess too late, you are not allowing time for intervention. If you assess too early, they might be missing the dynamic changes during the bridging therapy. And who to assess? Are you going to assess, or are you asking your nurse to assess, or your study coordinator? So we are always working in a manpower limited setting. And intervention is also something need to be determined, that requiring a lot of some of the referral waiting time as well as relevant expertise. So this is shared by the UPenn group. Then they do a survey, they realize that most of the transplant physicians claim they don't have time, they don't have clinical support, they don't have training and knowledge to carry out all this geriatric assessment. So if you're interested, you can read this paper in the Lancet. They're talking about how to set up a geriatric hematology service in the low and middle income countries. In summary, geriatric assessment identified a vulnerability that usually we don't capture on our routine assessment. And those geriatric domain deficits are highly associated with our poor transplant outcome. Peri-transplant intervention could potentially reverse the deficit and improve the outcome as shown by some of the study. And of course, we are waiting for more prospective study incorporating the intervention, ideally in a randomized way to tell us what to do. And geriatric assessment is not a one-man show. We need a multidisciplinary team care model. So this is my last slide, and this is my personal view. When during the COVID time, I found out that, well, if somebody was admitted into the ICU for 6 to 12 days with ventilator, it costs about 50 to 100 US dollar. And study coordinator, the salary is about 40K per year. So if you can avoid one ICU admission, that's enough to cover one study coordinator salary, and you can abuse your coordinator to do 100 geriatric assessment a year for you. So I'd like to thank your attention and happy to take any question.
Thank you very much, Lawrence. It gives us a very comprehensive understanding of problem in geriatric patients. After this talk, I think you will get a lot more referrals we will send all patients above 65 to you, and you'll get a lot more patients. Can we have question, please? Okay, so let me ask the first question. So in one of your slides, you showed that some intervention can improve patients from frail to pre-frail or from pre-frail to fit, some significant percentage. What are the pre-HAP that is done, and how long did it take? Because all these are relevant.
Yeah, very good questions, Dr. Lin. Unfortunately, I couldn't remember off my head what are the interventions they've done. But what they do is actually nutrition. They look into all the domains, and depends on what the patient's deficit on. Like example, walk speed are slow. They get a physiotherapy to work them up. Nutritions BMI is low. They ask the nutritionists or dietitians to look it up. So they are actually different allied health, and depending on the patient's deficits domain.
Question here. Thank you for sharing. We adjust some of our drugs dose based on age, for example, melphalan. So would charm scoring or other form of scoring be relevant here to help guide those drug dosing in elderly?
I think the answer is yes. So if you have a charm scoring showing the patient have a very high NRM due to maybe is very high, the fitness level and things like that are not the best, then that potentially you might want to adjust your dose. But bear in mind is you may be compromising the disease control. So in the end, it's a balance between NRM and also the relapse risk.
Any other questions? Okay, if not, we end exactly. Thank you very much.
you.
Thank you, all the three speakers, and thank you to the audience for your active participation.